In the mid 2000s, I started seeing a huge uptake on the number of heroin overdoses. And what I was really seeing was our crews are running a lot of dead young people. And that has a huge impact on the crews. It's one thing to have one every once in a while, and yes, it's trauma and it's going to build up. But when you're running one every 48 to 72 hours, a death of a young person, that has a significant impact on the responders.
Hi, everyone. Welcome back to Prevention Pioneers. I am your host, Laura Coons, and today we have a very special guest, Houston Park. Houston Park is the ultimate prevention pioneer. He has pioneered prevention in a variety of different ways, locally, nationally, internationally. Houston, I'm so excited for our audience to get to know you today. So let's start with them getting to know you and explaining to them all of the different buckets that you have your hands in your career, starting with where you're at now. So I know now you have an opportunity with the United States government. In the past, you've worked in fire and EMS at very high levels. You've pioneered opioid programs across the state of Florida nationally. So what are you up to now?
Well, thank you for having me. And to begin with, the position you just talked about, I was nominated by the Trump-Vance campaign to be the Assistant Secretary of Health and Human Services, with Secretary Kennedy being my boss.
Nice. No big deal.
Yeah.
I mean, that's unbelievable.
That process was put in front of me at the beginning of January. Here we are, almost August.
Yeah.
I think a little bit of Doge has delayed it.
Yeah.
But from my understanding, things are still moving forward and waiting to have an appointment for Senate confirmation, which is really exciting. I got to tell you, because an accumulation of everything I've done for over 30 years has touched in one way or another the majority of the responsibilities that I would have with Health and Human Services, specifically that with the Administration for Strategic Planning and Response. So everything from biological terrorism, biological natural occurring incidents, man-made disasters, vaccine research, opioid epidemic, behavioral health, it's all in there. So it's really kind of an exciting opportunity and a chance of a lifetime.
Yeah, it's amazing. I did look into that role and what it entails, and when also, and you and I have known each other for a while, so I have been aware of things that you have done in your career, and looking what this position entails, it does feel like it was made for you. So one of the areas of your past and your history that I'm super interested in is this crisis management consulting that you would do at the international level, consulting on weapons of mass destruction and helping people prevent essentially mass disasters. So talk to me about how prevention has weaved through your career.
Well, throughout my whole career, prevention and preparedness are a big part of what I've done, as well as response. I've been very fortunate. Even during my time in the fire service, I had a part-time job where I was consulting around the world for the U.S. government, preparing other nations for the event of a chemical, biological, radiological, or nuclear attack or a release. And with that, I would go to these countries and I would train other firefighters, other response agencies, how to be prepared, how to protect their communities, how to make sure that they were safe doing what they were doing. And that was all sponsored through the U.S. government in support of providing these countries with additional equipment and supplies and education and ongoing. I've been very fortunate. I've been all over the world to some amazing places, and just an incredible opportunity. And with that, it's just continue to reinforce a lot of the education that I have had in the past, my experiences with the fire service. I specialized in hazardous materials as a kind of like the primary direction that while I was with the fire department. Hazardous materials or weapons of mass destruction are basically the same thing. There's just a different delivery mechanism. One may be by mistake or accidental, and one may be by intention. And so when you really start breaking down those hazards, many of them are very much the same. So with my specialty in emergency medicine and hazardous materials, I developed a passion for toxicology. And so with that, when I'm overseas or even domestically, and I'm training a community to be prepared for, let's just say, anthrax, I have extensive time studying biological weapons and how they work. And at the same time, you could just switch that and say what we've also had to deal with real life concerns when Ebola was the concern. And so I was fortunate enough to train through the Department of Health across the state of Florida, most of the hospital systems and fire rescue agencies on how to be prepared in the event of something such as a Ebola epidemic within our country. The reality is we have really good healthcare here in the United States. We have clean water. We have antibiotics. We have all of those things that would reduce the chances of that type of an illness to spread, but there's still always the potential. And with that potential comes fear. So many times within the hospital systems or the first responder community, the fear of the unknown or the fear of what they've seen about Ebola or anything like that can paralyze a system.
Yeah.
So my goal is to educate them on the reality of these potential threats, how to respond to them, and how to do it safely. And so it kept building into all kinds of different avenues of providing care.
Well, and one of the things I mentioned earlier is you and I have known each other a while, and I have had the honor to get to know you as a human as well. And I would imagine when you're going overseas and doing these trainings, or you're doing these trainings nationally, it's also your ability to connect with people and to help them feel comfortable in your presence to receive that education that has made you so effective and successful. It's such an interesting skill set that you have, because I feel like a lot of people who know the technical piece maybe aren't as people-centered. Have you, in all of your travels and experiences, come across challenges where you truly felt there was a group not getting it, not understanding the education you were giving them?
I take a personal responsibility when I go and interact with different countries and agencies. And if I feel that after my team has been in working with these agencies and preparing them that they're not ready, then I have failed. So what I do is I make sure that whatever we're training them on, they're prepared. One of the interesting things about the first responder community and the military community is we refer to it as a brotherhood and a sisterhood. And so when I'm in these other countries and I'm working with individuals, always with an interpreter, because most of the time they don't speak English and I don't speak the languages of their country.
Well, I was wondering that as well in terms of effectiveness, you know?
So through the interpreters and now with amazing Google Translate and stuff like that, I'm able to have really good communications and conversations. So not only have I built friendships around the world, but an alliance of brotherhood and brother and sisterhood.
Yeah.
Because I believe that if it's my responsibility to work as a team and train others and they don't know what they're doing, they could potentially have harm to themselves or to their community, and then it wouldn't be right. And so when I have the chance to work with these individuals, at the end of the training, when I know that they have a better understanding of it, I always say this. I say, I pray that what I have taught you, you will never have to use.
Yeah.
But if you have to use it, you are prepared. And I'll give you an example. So I was in New Macedonia, and I was teaching their fire service how to deal with chemical and biological weapons or chemical emergencies. And I felt a need to really make sure that they understood everything that we were talking about. And their fire chief, basically a fire chief for the entire country of Macedonia, had me come sit in his office. And we immediately bonded. And because I was a firefighter from the United States and he was the fire chief of Macedonia, it was just like we immediately had that connection and acceptance. And so to be able to work with his staff and his training organization and share this information and make sure that they knew what they were doing was really important. And I've seen it. I mean, they have had incidents, not necessarily attacks, but they've had chemical releases by accident that they've had to respond to. And I've seen this in other countries as well. And they did what they're supposed to do. But one of the things I'm going to tell you that is just very, very real is in the fire service in the United States, or as a first responder, or as someone that's in the military, we see things that we should never see. And we are exposed to things that we should never be exposed to, or at least not with frequency. And so the bottom line is having a conversation with a local firehouse here and having a conversation with a firehouse in another country. We all have these same issues. We just short of post-incident stress syndromes, PTSD, we are all processing the traumas that we've lived through and other people's traumas. And so the commonality is that outside of the training, when we're having a meal together or something like that, or just all of the time that we've spent, we start to talk about those things and how to address those parts of our career and how do we work through it and what are the best ways to make sure that we're on the right direction for behavioral health and not carrying the burdens of what we do to where it ruins our life.
Right. And I imagine you have to proactively do that, and that many learn that lesson the hard way. It's like with so many things in life, you can be told that this is the best practice and this is the way to maintain your mental well-being in this role. But until the pain gets great enough, a lot of people don't truly understand the need and the value of that. And, you know, my background is in residential behavioral health care, and I've done a lot of work helping first responders and military into treatment. So when the crisis hits, when those things have built up over years and years and years, and, you know, in the residential treatment world, we say that first responders experience more trauma in 1 week than the average American or the average human, because, you know, we have a limited perspective. This is international. This is worldwide. Anyone in a crisis response role, you experience more trauma in 1 week than we will in a lifetime. So just to expect somebody to be able to naturally process that without tools and proactive knowledge, it's not reasonable. It's not a reasonable expectation.
Yeah, I agree with you. And the other thing is that those tools that are available for a long time, it was, you don't talk about it. You just do your job and you don't worry about it. But that's not realistic. So having tools, whether it's formal environments where you have an opportunity to learn about what you're feeling, what you're seeing, how does that impact your life, your family life, whether it's the formal tools or the informal tools, it's really important. And so now there's a much more awareness of what's out there, and to not just push it back or not to try to find some type of self-medication that gets rid of those challenges.
Yeah, it is amazing how much the awareness increased post-COVID, post-pandemic, and really everybody being more open to not just taking care of themselves in the mental well-being, but on the physical health side. Mm-hmm. You know, preventative health, preventative mental health. It's on trend. You know, I mean, this is really something that so many people are open to and embracing. And it almost swung to the other extreme. We were talking about that a few weeks ago, that now you have the younger generations that, are almost like could be called too soft with it.
I'd be careful with too soft.
Yeah.
I would say that the younger generation was brought up differently, very positively in most ways, but just different than the way I was brought up. And so the reality is that when you can share what you learned from a long time ago from somebody who has done this for well over 35 years to somebody that's brand new, there's going to be different coping mechanisms, but the bottom line is that you recognize it.
Yeah, I was going to say there's a lot to learn from each other in that, that because we have 5 generations in the workforce. So there's so much to be learned from everybody's perspective. And, kind of the best practice is going to fall somewhere there in the middle. And I think resilience is a term that can't be said enough in today's day and age. Just with the pace of the world, we have so much stimulation around us. And then you think of a first responder, fire, EMS, police officers, and then all of that compounding trauma. And that's just a lot of energy to carry. So in your experience, how have you built resilience? I mean, because for someone to, I think, move through the way that you have from a local level to a national level to an international level, there's no, and then me knowing you personally, there's no doubt of your strength and your ability to hold. But I can't imagine you have not had challenges along the way. And I think a lot can be learned probably from your experiences if you're willing to share any of those. Have you had any dips throughout your career of where you really felt the weight of everything you were carrying? Talk to me about that.
So I kind of went in and out of that throughout my career. And of course, as you get towards the end of your career, it accumulates. And so I'm going to just share a situation. I also used to be an ocean lifeguard before I became a firefighter and a paramedic and everything. And so I was an ocean lifeguard down in Miami, and I had a family of 7 people drowning. And other lifeguards, myself, and fire rescue responded. And one of the victims that I rescued, actually, I ended up doing CPR on, and it was a little girl. And so I was 19 years old. To me, that was an exciting day at work, but it was horrific because mom was in respiratory arrest. One of her daughters was in cardiac arrest. And so we were working, trying to, get both of them to breathe on their own and get their heart started and everything. But this is back in the early 80s. And so we loaded these 2 patients onto a police helicopter with no care. And they just flew to a hospital. And I thought for sure that both of them would have died. And not to mention the other 5 were very serious as well. And so I carried for 35 years in my head with all of the others, no resolution as to what happened to that.
Oh my goodness. I didn't even think about that.
And during COVID, I got notified by a family that they wanted to know what happened to them when they were near drowning victims back in 1984. And so they actually...
I just got chills. Oh my gosh.
So they actually went to the Miami Herald, and through microfiche, they researched the newspaper articles, and they found the article of this family that was rescued down in Miami. And so their mind determination was they were going to find out and meet whoever it was that was involved in bringing them back to life. And so they went down the channels. My name was in the newspaper article. They got a hold of me. My father shares the same name as I do. So first they got a hold of my father, and he's like, I have no idea what you're talking about. And then he's like, oh, well, maybe it was my son.
Yeah, that makes sense.
So during COVID, they are a Cuban-American family, very large family, very close. We arranged to have a Zoom meeting, and it was the first time I had heard from them. I had no idea they were still alive.
Oh my gosh.
So all 7 of the people survived. And the one particular girl was, I think, 2 or 3 years old. And now she's married. She has a family.
Oh my goodness.
And the most ironic thing is she married a firefighter from a department that I used to work in.
Oh, wow.
And so, but I was there before he was. So we never met. So I didn't know any of this. She didn't even know that. We're talking about it during the Zoom meeting because she didn't know that I had become a firefighter. And so all of a sudden, I'm able to get rid of all that stress of those people sitting in my head that I thought had died, and they're perfectly healthy. And then to see that her husband and the other little girl's husband are both firefighters. And it was just like this system of continuous care. So every June, they say they celebrate their life, and they always pay tribute to the firefighters and the lifeguards that came there and rescued them. This one girl did not even know that she was in full cardiac arrest, and that she had no idea. And I said, well, I did. That's back when we would do mouth to mouth. I did mouth to mouth on you. I did everything. And to be able to share that with somebody and then see that they're completely fine, and it just reinforces that it works. But that stress level, it's like I always say, and I've said this my whole career, that we can only put so much in a glass before it overfills. Yeah. And if you can pour out just a little bit each time and you get rid of that, it's gone.
That's a great image.
And so that alone, and I reached out to all of the firefighters that I could find still, and previous lifeguards that were part of that to share this story. Because I'm sure they were walking around with the same, if not many others that are inside our heads. And it just gave this amazing opportunity to just release that part and know that what we do works. Yeah. You can't get rid of all of it, but it helps.
Yeah, it gives the hope. Did that incident, is that what made you want to become a firefighter?
No, not really. When I was an ocean lifeguard, we got an incentive if we went to EMT school, 5%. So I went to EMT school, and part of EMT school was riding along with fire EMS. Once I went there, I was hooked. I just ran with it full speed.
So then when did leadership opportunities start coming your way?
Well, actually, they started as a lifeguard because I had worked up to lieutenant on the ocean rescue side. And then into the fire service, I always had an interest in helping train everybody. So in a sense, that's a leadership role. But after doing a couple years within the fire service, I think I was right at about 5 years, 6 years, 8 years, something like that. I started pursuing the requirements to be an instructor by the state and by the U.S. for International Association of Firefighters. And with that, as I moved through each year of my career, there's opportunities to promote to lieutenant, captain, and so forth. So those are leadership roles, and they're leadership roles on the front line. And so that's a big difference. And so building a team, knowing the strengths and weaknesses of your team. I was in a special operations group, so we did everything from dive rescue to building collapse, hazardous materials. I had to know what the strengths and weaknesses were of each individual, because not everybody really was 100% for all of those disciplines, but working together as a team, we were always able to complete what we needed to do. And one of the biggest challenges, regardless of what position or what role we were doing, was how do we deal with this afterwards? And so fortunately in the fire service, there was a thing called critical incident stress debriefing. And so when we had a major incident, we would do an informal, basically just a dialogue within the station, just talking to each other. That's probably our best means for immediate behavioral health success.
Oh, the peer support is huge. There's a lot of data behind that. And
I will say that the conversations within that firehouse or that fire station may be X-rated at sometimes, because it's just the way that we would emote. But everybody had an opportunity, and it was usually, it may sound strange, but it was almost always followed with just extreme laughter. And that laughter would help release some endorphins and make us feel a lot better. But then you'd get off shift and you'd have those reminders of the bad incident you just had. Yeah. And it could be a wind direction. It could be a feeling like touching cold water if you had dove in the water, a smell or anything like that. And it just re-triggers and you relive an incident as vivid as if it were just happening again. So learning how to deal with that through formal debriefing, counseling, physical fitness, nutrition, just kind of building on that is something that's really being emphasized now in the fire service, and was kind of like beginning then, but it really works.
Mental health challenges make up 10% of workplace healthcare costs and lead to billions in lost productivity each year. Traditional employee assistance programs were created to help address these challenges. However, they are often underutilized because they are focused on reactive solutions instead of proactive solutions. That's why we created Spirence, to prioritize mental wellness in order to prevent mental illness. Spirence's science-backed platform offers an extensive and continually growing library of mental health courses, crafted and delivered by clinical experts. The platform also features live events, interactive coaching, on-demand support tools, and dedicated support for managers. Our approach results in over 800% higher utilization than traditional EAPs. The world is moving towards proactive care, and Spirence is leading the way. Spirence, the future of workplace mental health.
That has been interesting to see the difference. Even in my career, almost 17 years in behavioral health and interacting with first responders for a big portion of that, seeing the difference of the time and resources invested now versus 16 years ago is pretty incredible. So did you see that shift in your career or your like acute part of your fire and EMS career? Or are you really looking back and saying, wow, like they really have it now. It would have been great if we had it back then.
I've championed that effort ever since I've been in emergency response.
Well, now I do know that about you. I think you've championed it way more than probably most people know.
So it was always available, but it's much more prevalent. And there's a really negative side effect to all of this. So the suicide rate in the military and the first responder community is the same. And it's off the charts. And so that's something that we're seeing with more prevalence now than we've ever seen. And so to have better refined tools, to use data that helps everybody understand where they are, what help's available. There's actually laws now in the state of Florida that support first responder behavioral health care. And so all of that's new, and I think it's invaluable. And it really, for the Florida Department of Health under emergency management or emergency EMS, that's one of the biggest priorities right now is first responder behavioral health, reducing suicides. Not only suicides, I mean, that's the worst case scenario, but if you look at divorce rates, they're much higher in the first responder community and the military community than any other form of work. And so by having all of these different resources available, it only can make us healthier.
Well, yeah, there's so many layers of it because you have the percentage that have not developed a mental health condition yet. You have those that are actively out there every day who have, a developed mental health condition. And then you have those who are in that 1% bucket. And actually for first responders, that's much higher, where they're potentially in crisis. And that's where you're dealing with the suicidal ideation. That's when you're dealing with, they're needing immediate intervention. So it's tough because some of the conversations that I've had recently and that you and I have had, it's now you have the unions and you have the teams getting resources for all of it and assessing each person to really know where they are. Because I think that would be the biggest challenge. I mean, yes, you can go back to the firehouse and you can talk about the incident and you can debrief. But to your point, that person goes home and they may have other factors in their life that nobody knows about. Their wife might be considering leaving them, or might have had an affair. Their child could be sick. They could have a parent that they're helping through a chronic illness. So there's just the real life stressors too. So it's like, how do you really know where someone is without some level of assessment, without base layer awareness campaigns and a truly open forum to talk about it? In my time getting to know you, I know that you've really been, as to your point, a leader in that. And you've always talked about it openly, and you've even led large-scale operations on the prevention side. One particularly comes to mind is your work with the opioid epidemic in Palm Beach County. And I would imagine that came from your work as a first responder, just seeing the effects of opioid use on Palm Beach County, watching people die unnecessarily. How did all of that come about? Like, how did you first get involved in your work with the opioid epidemic?
So I want to answer that, but I want to touch something I want to go back a little bit. So you talked about leadership. So as a captain or a lieutenant in the fire service, you have leadership responsibilities. You manage an incident, you manage a scene, you direct your people, your team to do what needs to be done, right? That's easy. But when you're the lieutenant or you're the captain in a station, and just like you just mentioned, and one of your firefighters is going through a divorce, one of your firefighters' spouse has cancer, one of your firefighters' children is sick,
Yep.
one of them is getting divorced. That's the real leadership, is when you start to learn how to, because they all come to you. And so now the easy part of the job we train for all the time. Now as a leader, you're dealing with that part of the work, which is what we do every day. And now the human dynamics. And that's very real, because you could just say, oh, well, that's none of my business and walk away. That's not right, because you're a team, you become a family.
Yeah.
And so you become very involved with each other. And so that is to me, that is a big attribute to being a positive leader in the first responder community is, your job, but how well do you interact with your team, and what's the support that's there for them?
We talk a lot about that on this show in every industry, that leadership layer. And it's not just the executives. Yeah, the executives of any organization can set the tone, but it's those middle managers, and that it's those on the ground every day running the team. It's that leader, that can have a positive or negative impact on that individual. And so that person having the self-awareness, that person practicing what they preach and go and emptying out from their cup so that they can take a little from others. Yeah. So I'm glad that you were willing to share that mentality, because I think that will help a lot of the listeners, just that imagery alone. And, I don't know about you, but one thing I've learned, at least for myself as a leader, what empties that cup is different for every person.
Absolutely. So that will lead right into the opioid discussion.
Yeah.
Okay. So, and I just want to say one thing. So as a first responder, dealing with children is probably one of the more stressful type of calls that we run.
Yeah, I've heard that. Yeah.
As you get older, children become older, right? So somebody in their 20s, as far as I'm concerned, is a child, right? Yeah. Because that's how I relate to my children.
Yeah.
Okay. And so while I was still out in the field working in the station as a special operations captain, we were running EMS medical calls, fire calls, and everything else. But in the mid 2000s, like starting around 2010, 2012, I started seeing a huge uptake on the number of heroin overdoses that we were seeing. And what I was really seeing was our crews are running a lot of dead young people. And that has a huge impact on the crews. It's one thing to have one every once in a while, and yes, it's trauma and it's going to build up. Yeah. But when you're running one every 48 to 72 hours, a death of a young person, on average, maybe 22 years old, that has a significant impact on the responders. And so what I was seeing is that we were seeing way too many overdoses. And so my desire and knowledge of toxicology and hazardous materials, and also as a paramedic, I knew that, everybody's giving Narcan, and Narcan is working perfectly on these individuals that have overdosed if we get there on time. If we don't get there on time, it's another death. And so I knew Narcan is a reversal, but I thought, well, let me put my toxicology mind on and my view of how things work and do some research and find out what else is out there that can stop this opioid challenge. And I started researching, and I came across an article that was written by one in Yale and one in Harvard about this medication called buprenorphine that they were using in a church, and individuals were coming in, self-signing up for treatment. And they were provided buprenorphine, now commonly referred to as Suboxone. Right. And they were showing like 90% success rate on not returning. And so when I read this article, I thought, well, I wonder if we could do that as firefighter paramedics when we come across these patients. And so I presented it to our medical director, because as a paramedic, we can do anything that our medical director signs us off to do. And he he didn't even know what buprenorphine was. He'd never heard of it.
When was this?
This was, I really started pushing that in 2014.
Okay.
And he wasn't too sure of what I was talking about was real, but I knew he was data driven by science. So I got the hard data and I said, here you go. Here's the plan. I said, I want to create a team. I want to go with, when we respond to an overdose. We'll get them to the hospital where we will reverse them with Narcan as we have done. And then I want the hospital to induce them on buprenorphine, Suboxone. And this was like, people thought I was crazy.
Yeah.
Because
I remember that.
2014, 2015, physicians were required to have what was called an X waiver, which allowed them to, it was a DEA separate license that allowed them to give Suboxone for opioid addicted or substance use disorder. So there was a lot of resistance. A physician could prescribe unlimited amounts of OxyContin, but could only treat in their initial year as an X-waivered physician 30 patients.
Oh my goodness. I never knew there was a cap on that.
There was a cap. And then it went from 30 to 100.
Wow. I knew there was a special license. Did not know there was a cap.
So that just doesn't make sense.
No, I was wondering if you found out why in your research, because knowing you probably did.
I did. There was a law written in Congress that required for that type of medication, and where it was scheduled, that physicians were, because they wanted to maintain like accountability, right? That was a huge obstacle. But anyways, what we did is we started taking patients to the hospital. The hospitals bought in on it. They were giving them buprenorphine, and then they were discharging them. And I'm like, whoa, we have to follow up on these patients, and we can't just give them one and say you're good. So we created a team, and it was actually the beginning of what they now refer to as mobile integrated health or community paramedicine. And so our team, consisting of peer specialists, those are individuals that were invaluable. They were somebody that had lived with a substance use dependency. They were clean and they had received specific training. They would come with us as a paramedic team, and we would meet these individuals upon discharge from the hospital, and we would treat them for 7 days straight in their home, in the woods, wherever they lived, we would treat. One of the requirements is that they had to live locally here in this county and have a residence. Well, many of them were without homes. So I became very creative on where my individuals lived. There was a fast food restaurant, and almost all of them had that address. But what we did is we would go out and we would start treating these individuals with buprenorphine. And then after 7 days, we handed them over for long-term behavioral health care and medical assisted treatment with the healthcare district. And it took about 3 months for it to really start to take effect. And then all of a sudden people were like, this is the best thing in the world. Going back to 2016 to today's date, our initial patient load of 100 patients, we're still at over 65% of them have not returned to their drug use.
I mean,
it's 2025. It's 10 years.
Oh gosh, see if you just
and I was so fortunate because that's right about when I met you. Yeah. And we had that opportunity to go up to Cincinnati and offer this same program. And it was so ironic because we went up to Cincinnati and I hadn't even kicked it off yet in Palm Beach County, but it was just in the works.
Yeah.
And so I already could see then that there was a need and we could share this and we could really make it work. Well, that program that we initiated became a model.
I could see it. Yep.
So in Florida, there's 67 counties. We have this program running in 47 counties right now, and it has been replicated across the United States. So from California to Alaska to Rhode Island, you name it, there is some form of medical assisted treatment being done. And many of those are using the EMS providers to initiate it. And it has rapidly changed. So what we initially started where the hospitals were doing it, we are now doing it. I worked with a doctor, Dr. Courtney Phillips. She's a psychiatrist, and she and I wrote a protocol for the state of Florida. And it now allows paramedics with their medical direction to pre-induce a patient before they get to the emergency room with buprenorphine. And what that does is it stabilizes a patient in the ER so that they're less likely to get up and walk out. and repeat. And now they're going to listen to what are their options for treatment. And so this system continues to grow. And I would tie that back as this opportunity to go work with Health and Human Services at the national level.
Yeah.
One of my primary responsibilities would be epidemics.
I was wondering,
So,
yeah.
The opioid crisis was labeled a national epidemic back in like 2018, 2019. It's still there. Yeah. COVID came in and took a big bite out of that. So people forgot about the opioid epidemic. And actually during COVID, the number of deaths went up because of isolation and behavioral health challenges for those that were dependent on different substances. So there's been a lot of emphasis to retrain or change the direction of these individuals. And so now it continues. I push for it every day. We hear amazing stories of people who have not only gotten rid of their dependencies, but they've reestablished their lives, their families. They have children, they've moved on, and they've checked back into the world.
Yeah.
So that was the most rewarding thing I've done in my entire career. So people used to say I was crazy because I would go with these peers and I would interact with these patients. And as a first responder, we build a wall. We put a wall up there where we've seen enough trauma, we've seen enough abuse, we see everything. So it's just cut and dry. You know, we become like robots.
Yeah.
But I started interacting with the patients and hugging them. Okay. And people said, oh, here's the crazy captain hugging everybody in the hospital without gloves, which was really difficult for me to abandon that. But the thing is that we asked every one of our initial 100, and there's been thousands of them since, you know, what made the difference? And, you know, they say, oh, well, of course, pharmacologically speaking, that medicine works. Yeah. But they said the most important thing that they got out of it was that they were treated with respect and they felt like they were a human. Mm-hmm. And so when we would interact or when I created a team, I had some requirements: compassion, no judgment, and treat the patients like your family if it's family members you like, and do your best to provide care for these patients. It has gone from opioid dependencies to all substance use disorders. And so we can treat it all. Some of them are a little bit more challenging than others, but through behavioral health counseling, awareness, getting rid of stigma, having a compassionate, caring team that goes after each individual, treats them as a person, we're having amazing success. And that model can be replicated over and over and over again across the United States, and we can combat the opioid epidemic.
Yeah, it is unbelievable how that blueprint took off, honestly. And at the time when you and I went to Cincinnati, so the audience knows, Houston and I, so at the time that Houston and I met, I was doing some work with the International Downtown Association. So this was an association of kind of best practices for the downtowns of major cities nationally and across the world. And a top topic was the opioid epidemic and the homelessness that it was creating in cities across the country. Nobody knew what to do. My path crossed with Houston, and I knew about this program that they were trying to put together down here. And I asked him if he would come present to the International Downtown Association. And from that, my hometown of Cincinnati invited us up. They invited Houston up to present to their stakeholders. And some really amazing things, I think, came from that based on the information you shared while you were up there. I honestly, looking back, didn't realize that program wasn't fully launched down here back then. But back then we had I think we were one of the more concentrated areas in the country, right, for the opioid epidemic and the deaths. And we were also had the pill mill situation going on. So something had to be done down here. And then I think over the years, it increased in other cities across the country. Do you know how many cities it's been replicated in, or?
Well, in Florida, 47 counties of the 67. And so within those counties, that would include all of the cities. Okay. And then some of the big areas where we've seen success in Indiana, Indianapolis, LA, San Diego, Rhode Island, Connecticut. I mean, it really, we've reached it. It's gone everywhere.
Yeah.
And
IDA probably took,
Texas,
you have no
done,
idea how many cities took that from IDA, International Downtown Association.
Yeah. And it really just makes a significant difference. And I'll tell you that one of the paramedics that was working with us, the most amazing paramedic you could ever work with, this was the guy you wanted to be with you for your worst case scenario. If you had a horrible trauma in your life physically, this was the best paramedic that was going to work on.
Wow.
And
where's he located?
He's retired.
Okay.
Yeah. But the really exciting thing about that is that when he came on the team, he said to me, now I just said that he was the best person to take care of you, right? But if you wanted someone to hold your hand and be compassionate, that was not the person. Okay. That wall was there, right?
Yep.
But he came back to me and he says, towards the end of my career, you handed me an opportunity to reignite the passion of doing EMS and showing care. So he went full scale. His station, because he was a captain as well, it was actually adopting some of the children, not legally adopting them, but emotionally and physically going to the hospital for these children that were born with addiction and helping hold them and feed them. Some was under 6 months old, and they would go there every single day and take care of these children while the mother was in rehab.
Oh my goodness. Oh my goodness.
And so when you see an entire station, a fire station, and his particular one in Palm Beach County, they like to say that they're the busiest, the big bad firefighters of the county.
Yeah.
Hardcore firefighters. They were going on their days off and hanging out in a ICU unit with newborns, holding them because there was no other care. It's just huggers or holders. And they were holding these babies, and then they were bringing formula to the hospital and clothes and buying new clothes for the babies as they grew, because they would stay there sometimes a year. And this fire station adopted these kids within the station and the hospital just out of compassion. And it reignited their compassion, and it reignited that part of what they missed in EMS.
Yeah. And I also think that purpose and meaning is an antidote to pain too. It's a way to transmute some of that.
Sure.
And I mean, as a first responder, your whole career is meaningful and purposeful. But there's a significant amount of pain that comes with that. And so I could totally see how it's okay, this is because you don't always see the success stories, to your point of the lifeguard incident. You don't always see how that pans out. You don't always, get that call saying thank you. In fact, in today's day and age, you sometimes get the opposite of a thank you, which I can't even touch on. I get so angry of how anyone could disrespect a first responder or member of our military. I can't even.
And I would add to that the hospital staff, the nurses and the practitioners, all of the staff, they see the same thing, but accelerated. Because imagine one fire station running so many emergency incidents a day, and then having 50 of them going to the same hospital day after day. And it's the staff seeing the same thing. So even the hospital, we reduced hospital readmissions by that population by 87%.
See, now that's an interesting point to think about as well, because how many people were being affected by the opioid epidemic? The families.
Yes.
Your teams. If we really, I'm sure you played that tape through to develop the program. We were talking about weapons of mass destruction earlier. Opioids. At one point, and still, although they've cleaned up a lot of the illegal prescribing of them, at least down here, at one point that I think those were considered a weapon of mass destruction, right? By some definitions.
Well, again, a weapon of mass destruction or a hazardous materials incident is, if it's released, it's the intent that defines it.
Okay.
So when you have the analogs of fentanyl that are out there right now, and the potential for how many deaths could occur with acute exposure to certain levels of fentanyl, that truly is it could be used weaponized.
Yeah, absolutely. And absolutely.
Yeah. So when you look at the potential of chemical warfare agents, I mean, there are chemical warfare agents out there that will utilize a narcotic. We've seen it. We've seen there have been various terrorist activities where they've used products like that, and it works.
Yeah, I think you've had to get involved in some of those, right?
Unfortunately, yes. But the reality is that my hazmat and toxicology background led me to the treatment for opioid use disorders.
I look at it and I just think it's beautiful, but what makes it even more beautiful is that is honestly the person behind it. I mean, it's been such an honor to get to know you. So in your career as in fire and EMS or any of it, have there been things where you're like, oh my gosh, if the average person just knew to not do this, it would prevent fires, it would prevent deaths, it would prevent, what are the top things that come to mind for just dumb ways to die for our audience?
Well, I want to be respectful of that, but I will say this, we all, for the most part, love animals and nobody likes to see an animal suffer. But if an animal is injured in the road and you step out to help that animal and you don't protect yourself, that's a really dumb way to die.
Oh, goodness. Oh, okay? Goodness.
Preventing fires. I mean, if you're cooking on the stove, don't leave it on the stove.
See, now that's something because people forget to turn the stove off, but it could also be they left that pan on the stove.
And I mean, that's pretty easy. And, wear your seatbelt, right? What's interesting about that is seatbelts were mandated because of the number of deaths that occur. It was one of the leading causes of death in the United States at one point. You know what surpasses that now?
What?
Opioid overdoses. Opioid overdoses surpasses the number of vehicle deaths for people that are in comparison.
Now, that's incredible. I will say still that it would still surpass that with all that has been done to combat that epidemic. So if that doesn't show the scale of that epidemic at one point and just how far we have to go to be steps ahead of it.
So car accidents also led to what we know now as a trauma center for the hospitals, right? They were basically created because of the frequency of people with severe injuries, multiple injuries, and they would present to the hospital. So in our model for treating opioids, we did the same thing. We've tried to create a system of care specific to substance use disorders so that when a patient is brought to a hospital, that hospital treats them with the appropriate medications. The first responders can start that, and then there's an avenue where they hand them off for continued care.
Which I think is one of the best parts about that program is that you put behavioral health care forefront.
It has to be. I mean, you can't just rely on a medication to have success. You have to have, and people used to say, oh, you can't have these patients in your program because they're smoking pot or they're drinking or they're using cocaine. And I'm like, listen, let's focus on the ones that are dying right now from opiates.
Yep.
Get them streamlined into behavioral health. And maybe then we start to address why are the other dependencies there. And then through that investigation of their own, they start to get behavioral health changes and they no longer become dependent on those substances.
Yeah, absolutely. And even psychologically for that individual, helping them to prioritize behavioral health care and all of those different elements that it's going to take to get them well. They may not adopt that then, but what we know about healing from substance use disorders, it's all about planting those seeds.
Mm-hmm. And nobody wakes up and says, I'm going to become addicted. Right. And when you really dive deep into this program and you see the traumas that cause people to get where they are, I just wish everybody that looked at somebody with a dependency would take a step back and say, I'm not really sure why they're there, but I can help them. Because when you peel that onion back, layer after layer, there's more and more things in there that attribute to why they are where they are.
Well, we have data to help people understand why they are the way they are. But when the stigma's so thick, nobody's even interested because so much pain has been caused by that person's, substance abuse. But actually on our last show that came up, that the root of a lot of substance use disorders is trauma, and trauma that where people are victims.
Victims, trauma, physical trauma, psychological trauma, all of those traumas have the same effect on our bodies. I recently read a book called The Body Keeps the Score.
Love.
A very difficult book to read, but I'm telling you that has the scientific data to show you what trauma, and I'm not saying just trauma by, like, let's say falling or a car accident or something like that. I'm saying when you understand a emotional, physical, psychological type of trauma and what it does to your body, and it has it kind of continues on out. So you have a physical trauma, let's say from a car accident. Yeah. And then through that, you have other traumas that are associated with it, like maybe lack of care that creates trauma to that individual, right? Or lack of follow-up. So all of those things come together and they make it worse. And so trauma is trauma, and your body definitely keeps the score.
It's a difficult and beautiful process, both to unpack that and to heal. But that's come off on the show before as well. That's why people who do embark on a mental health journey or go into recovery, it's, they're heroes too.
All of them.
Oh my gosh, it takes incredible strength.
And I can say that at the end of my career as a firefighter, and now as a more mature man, I seek what will make me better and live a lifestyle that makes me better. And that's a challenge. But every day I get better. I mean, I get better at who I want to be. Yeah. And I think sometimes as adults, we don't learn that till later, or we ignore it. And it's really important that we go find yourself.
Yeah. Yeah. The journey of self-awareness, it is not for sissies.
Right.
And it's so funny because the opposite mentality historically was that it was for sissies, but it's the opposite. It's a very, very difficult journey. So I have immense respect for you. You've done all the difficult things now in all areas. Now you're, and I'm excited to see what you do for our country in this new role. I am definitely going to be fangirling on your career. And, as I mentioned, I just love you and your family. So
thank you.
Thank you so much for being here with us today, Houston. Thank you for your time. And thank you to our audience for listening. Don't forget to like and share this episode, and please spread the word about Prevention Pioneers.